Universal health coverage. So what does this essentially mean for low-income earners and the uninsured? Will the mandatory contributions help deal with the funding gaps at NHIF and see more Kenyans covered? Well, Dr. Frank Wafula, senior lecturer in healthcare management at the Strathmore Business School, is standing by to join me for this discussion. But first, let's take a look at a few statistics on the state of health coverage in Kenya. Well, currently, only about 20% of Kenyans have some form of health insurance coverage, and over 85% of them are covered by NHIF. For those in the formal sector, NHIF coverage is near universal, but just 15% of the informal sector is covered by NHIF. Now, as it stands, NHIF cover for those in formal employment requires a mandatory monthly contribution of 500 shillings per family, which caters for a principal member, their spouse, and their children who are under 18 years. Informal sector households can sign up for NHIF by contributing 6,000 shillings per year. Now, the new law will see all adults compelled to pay 500 shillings monthly or 6,000 shillings annually in a remodeled universal health coverage scheme for outpatient and inpatient services that include maternity, dialysis, cancer treatment, and surgery. The new law targets more than 16 million adult Kenyans who are not covered by NHIF. Official data shows more than 25.36 million Kenyans are above the age of 18, and the NHIF has nearly 9 million members. I beg your pardon. All right, so let's bring in Dr. Wafula in on this. Dr. what changes does this new law actually bring?
Good evening, Victoria. Happy to be here again. So in a very simplified way, there's two fundamental things that are very clear in the new law, and that is the government's strategic move towards strengthening this body as an organ that purchases services on behalf of Kenyans, what you sometimes hear referred to as strategic purchasing role. But the interesting thing is, and perhaps the more contentious one, is a second kind of bit that comes out quite strongly, and that is repurposing NHIF to become the vehicle for universal health coverage. And I think that's where there's quite a bit of contention. So that's really expanding its mandate. And of course, some of the things you've talked about are some of the more stormy aspects of the bill, introducing compulsory contributions, mandating employers who employ people who earn a certain salary to top up so that they actually meet this new statutory obligation, and such new additions. But those are the two key components of the new law, so to speak.
Right, so we know NHIF is trying to net more Kenyans, at least under the scheme. But the question that a lot of people have been asking is, are the mandatory contributions practical when you think about just the general financial case for many Kenyans?
Yeah, that's really a difficult question, Victoria. So first of all, I think there's sound logic to making contributions mandatory, because if you don't do that, and we've seen this over the years, then you end up with what is called a sick pool. So how does that work, Victoria? It basically means that those who are mandated to collect these as employers and remit to NHIF will play their roles. But anybody who just needs to sign up voluntarily may not always do that. And what we've seen over the years is people only signing up to NHIF when they need the service. So if I use a very simple example, I need a procedure about 100,000. I sign up, I pay for 3 months. That is about 1,500. I get the service, it's paid 100,000, and then I disappear. So basically you have, you're talking about maybe 10 million individuals, 10 million contributors. I think statistics indicate only half of them are active. And if you to look at these numbers further, particularly the voluntary contributors in the informal sector, the numbers who are actually active are much lower than that. So the voluntary nature doesn't just work. But I think more directly to your question, it's a really difficult question to answer, because, and I always insist that the challenges that NHIF have are not, health systems or health financing challenges. They're not even legal challenges. So these are things that are very fundamental to us as a society. So what happens how do we look at risk of getting sick? How do we look at the idea of paying into insurance when I'm not sick, just to make sure I'm covering someone else? Because Victoria, insurance, particularly social health insurance, which is what the government and Kenya is trying to repurpose NHIF to become, is based on the principle of social solidarity. So I'm paying to take care of everybody. The older, the younger are taking care of the older. The sick are being taken care of by those who are well. That kind of arrangement. And of course, those who have money are taking care of the poorer. But unless that fundamental isn't there, then, as they say, you cannot legislate against the hearts of men. So I think it's a mixed bag. We can see why they're doing it. How this is going to play out, considering this broader kind of view we have on social solidarity, isn't as supportive of this move. It's only to wait and see how this will work out, Victoria.
Right, and I guess beyond inculcating that whole social solidarity among Kenyans, there's another issue that Kenyans have with NHIF. They have huge trust issues when it comes to how the funds are managed. There was a quote in terms of how much is actually collected by NHIF, about 55 billion shillings, but 10 billion shillings a year is lost to fraud claims or fake claims or other scandals that happen within the fund. So how do they improve transparency, especially if they're going to increase the contributors?
Yeah, so I think that requires and that's a really good question, I think. So that requires a very systematic approach, because I believe the challenges with NHIF, or broadly in our health financing space, have started, kind of operate at three levels. So the institution itself, the market where it operates, and particularly the kind of relationships they have with their clients, and the kind of contracts they have with the healthcare facility, and how the payments work, and how the contracting works, and everything else. So I call that the mid-level. And then, Victoria, there's that kind of high-level macro challenge, which is political, so political interference. And so in a sense, Kenyans have problems with all three levels, and that's what makes it really challenging. To be fair, those of us who perhaps have looked at how NHIF has performed over the years, there's a lot of improvement that doesn't actually isn't necessarily appreciated, particularly at the institutional level. So you talked about the funds that are collected, nearly 60 billion. 92% of that is payout, is kind of paid out. It's not ideal, but it's a much better scenario compared to what this was 10, 15 years ago. So there's a lot of improvement at the institution, but this doesn't come out very strongly. I think the biggest challenge is the market and at the macro level, because there's a lot of fraud, there's a lot of gaming. We don't have very good information systems. And so, people who are being seen are not necessarily the people who are contributing. And of course, there's, spurious claims and everything else. And of course, there's the whole kind of bigger issue around the macro. Kenyans don't necessarily trust the institution. So I think to improve transparency and to build trust, we need to stop looking at the challenges within NHIF as health financing or health systems challenges, and actually look at them as fundamental challenges that pretty much cut across a lot of our institutions. And the approach should be multifaceted, very geared towards making these changes and letting Kenyans know that this is a growing and improving institution and their money is safe. And of course, guaranteeing that the political interference doesn't mean that they're paying money and the money is going for other purposes. So I think all these things have to be handled at all three levels, Victoria.
Right. And lastly, before I let you go, Dr. Wafula, we know the end game for the government, for NHIF, is to cover literally every Kenyan under universal health coverage. But, what's the best way to do that? Or is there an alternative that's a bit better?
Yeah, experts in this area are very divided on the best way of doing this. I've never been a big fan of insurance. That's a personal bias, simply because, we were British, we are a British colony and, very much a tax-funded system. Victoria, Kenya is a country where everybody says serikali nisaidia, so whenever they need. So there's always that kind of path-dependent belief that the government collects taxes for us and it takes care of us when we're in need. So whether this is, in hospital, whether it's education. So I feel a tax-funded system that is similar to what operates in the UK, which because at independence we adapted these systems, would have worked better. But that's kind of crying over spilt milk. So I just think it's really difficult to get this to scale simply because of how Kenyans look at risk, how Kenyans look at paying when I'm not using this service. And that is actually really, really complicated by what's happening out there. But having said that, what this new kind of amendments are bringing in is actually very positive, because Victoria, there are three things that need to come out clearly. Is one, the contributions have to be mandatory. It might take time, to scale, but that has to be there. Number two is there has to be very clear conversations around how you handle the three main groups, so to speak. So these are the employed who, have always been well taken care of because this is deducted from the pay slips. And then you have those working in the informal, sector, that actually have gainful employment, self-employment, so to speak. And then you have the indigents, those who are very poor, that to the extent that they can't take care of their needs. So I think there was an attempt to try and address this, and I liked that aspect of it. I think it was a bit of an anticlimax, because in the end, some of the provisions that were there about, kind of forcing or mandating the counties and national government to pay for the poor, I think those were removed eventually. And the third thing that I really liked is the fact that setting 500 shillings per month as a mandatory contribution is a good thing, because let's say you're a domestic worker, Victoria, who maybe earns 12,000 shillings or 11,999. At the moment, you're remitting 400 shillings for them for NHIF. So what this law says is now you're going to have to remit 500 shillings because you need to top them up to make them comply with the law, and you cannot deduct that extra 100 shillings from their pay. So that also protects the lower income earners. So overall, I think it's a good law. But like I said, ignoring anything about the health system, the legalities and everything else, there's a bigger question around the country. Are we ready to embrace social solidarity? And is the government ready to work with us and stop treating this as a health system or legal matter, and actually go to the community, go to the households, and figure out how we can partner together towards building this social solidarity, Victoria?
Dr. Frank Wafula from Strathmore Business School, senior lecturer there on healthcare systems. Thank you so much for your time. Always good having you on the show to shed more light on these issues. On that note, we take our last break here on Citizen Weekend. Here's what's coming up in sports.